sant yàlla.
looy xaar utal Wave nga scan nga fay te nag doo ci yokku dara.
Jar Oil Company stands tall as a trusted name in energy, keeping the Gambia moving with service stations across the country and a commitment to innovation and reliability. In Farafenni, Jar Group is reshaping our industrial landscape. The Jar Oil Cement Factory can produce up to 100,000 bags a day, reducing imports, creating jobs, and building a stronger Gambia brick by brick. And in the heart of the Central River region, Jar Farming Initiative is cultivating food security. With thousands of hectares under development and modern irrigation, Jar Farming is turning the Gambia's soil into abundance. Jar Group is more than a company. It is a vision of self-sufficiency, resilience, and progress. The Jar Group of companies, investing in industry, agriculture, and energy, building the Gambia's future today.
A better way to pay your UTG fees with instant proof of payment and real-time student portal update. Paying your University of the Gambia fees has never been easier or more convenient. With EcoBank, students, parents and guardians can pay UTG tuition and related fees through our secure digital banking channels such as EcoBank mobile app, EcoBank Online, and EcoBank Omni Lite. Once payment is completed, instant proof of payment is generated and the UTG student portal is updated in real time, allowing students to proceed immediately with registration, course selection, and clearance without unnecessary delays, while giving parents and guardians peace of mind that payments have been successfully processed. How to pay via the EcoBank mobile app. Open the EcoBank mobile app and navigate to the home screen. Select Pay Bill. Choose Pay a New Bill and select Schools from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. How to pay via EcoBank Online or Omni Lite. Log in to EcoBank Online and Omni Lite using your credentials. Select the menu and choose Bill Payments. Choose Quick Bill Pay and select School from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. Walk into any EcoBank branch or pay through our digital channels and enjoy instant proof of payment with real-time updates on the student portal. EcoBank, the Pan-African Bank.
It's 22 minutes past 8 o'clock in the morning here in the Gambia. This is Coffee Time with me, Peter Gomez. Live on radio 92.1 on the FM band and www.wcr.gm for our global audience. We are broadcasting, of course, from the Gambia. Seated with us now is Dr. Abdoulie Ba, only the second consultant pediatric surgeon in the Gambia. His presence is a reminder of how far our health sector has come and how much further it can go. Dr. Ba represents a new chapter in specialist care for Gambian children, and we are honored to have him here to share his journey and insights. Welcome to Coffee Time, Dr. Ba.
Good morning. Thank you, Uncle Peter, for having me.
I always say this, doctors are increasingly getting younger and younger.
Yes, sir.
You know, when I was a child, when I was, a teenager, doctors tended to be gray.
Yes, sir.
So what inspired you to specialize in pediatric surgery? And what was the journey like?
Okay. Thank you so much, sir, for the question. The journey started with the University of the Gambia.
UTG?
Yes, UTG, School of Medicine. I was part of the 6th cohort, and it took us 7 years to finish. We started around 20 students. We finished with 10, so with 10 that graduated. So from there, I continued my journey as a house officer and then medical officer at the Edward Francis Small Teaching Hospital, where
Your boss likes you to mention the hospital, huh?
Yes.
As often as you can.
Yes, because it's a pride for all of us. It's the ground for our training, and it's still a ground for training and mentoring younger people. So from there, when I just finished my house job, there was no local residency training. Works were still ongoing.
So house job in your language is apprenticeship.
Yes, more or less.
Okay.
It's the most junior cadre of a doctor. That's when you just finish medical school. You don't have a permanent license, meaning you're working under supervision. Okay. Yeah, so that's what the house job means, which takes 2 years before you are licensed by the Medical and Dental Council of the Gambia. Then after that, you have your permanent license. That's where the medical officership starts. So during my rotation as a house officer, I had always had the intention of working with children. I even did my electives in UK in pediatrics. So I started with pediatrics. I saw how they needed help. There was a great need for specialist pediatricians. But I ended up in surgery, where I realized I had a greater impact as a doctor. I was taking care of patients and seeing results. So then with the passion of being a pediatrician and a surgeon, it all fell in line after my membership exam to enter into pediatric surgery. So it all started when I was in the medical school, having the love in caring for children. So after I was among the first batch of residents after we got the accreditation in 2018 under the West African College of Surgeons. We were 2 in surgery. My other colleague, Dr. Kamara, was here in the program. Then we had 4 others from OBGYN. So I finished my membership, which was a rigorous training done in the Gambia with rotations in different specialists. Then I passed the exams in 2011 under the West African College of Surgeons. But because pediatric surgery was not, or is still not accredited to train in the Gambia, I had to spend about 8-9 months in the Gambia before getting the scholarship from Kids OR Smile Train, which I'll be very thankful to mention. Yeah, sure. They were very helpful in giving me the scholarship.
We're grateful that they gave you the scholarship.
Yes, to go to Ghana with the support of the hospital as well as the government. It was a partnership because it was very clear. You go and train, but you have to come back, which was okay because that's the passion.
Were you bonded?
Yes. Okay. So it was a partnership. Even with the Smile Kids OR package, it's very clear while signing that you have to come and serve the people of your country, so which I'm very happy to do. Fantastic. So I spent 3 years in Ghana doing my rotations in pediatric surgery. I was appointed as a supernumerary resident, meaning I was not directly paid by the government of Ghana. Okay. So I was given a study leave with salary from the hospital to undergo the training. So after I finished, I had to come spend some few months still undergoing some mentorship and coaching under Dr. Cherno Jallo, who is the first pediatric surgeon in the country. And then I have to enter for the exams, which came out successfully in April. Okay. So that's how the journey goes.
What were your biggest challenges training both at home and abroad?
The biggest challenge for the membership was you realize we were the first batch. So you realize a lot of things were not in place. I must admit.
You were the guinea pigs,
yes,
if you like.
Sir. So, but I must admit our mentors and consultants and supervisors were keen to make sure the program goes. So that was one of the challenge. And also trying to make sure that this program continues. It needs a lot of things to be put in place, making sure data is set. Because if all of those things are not in line, the college will not give you the accreditation. So that was one of the challenge. and training. But I could say it was okay. The biggest was leaving the Gambia to go to Ghana, trying to blend with the culture, serving other people, and trying to also blend in.
You know, we have so many similarities, Ghanaians and Gambians.
Yes, there is a similar, but you realize that it becomes, you try to adapt. The food is similar, but it's a bit different. The culture is similar, but there is some difference.
Sure.
You realize the day-to-day activity you're used to in the Gambia, you have to change that a little bit, knowing that you are there for one purpose. No much socialization.
But Ghanaians are just as easygoing, as laid back as we are.
Very
Gambians.
lovely people, and shout out to all of them, my colleagues. They made me feel at home.
Fantastic.
So it was really wonderful experience.
How would you describe the current state of pediatric surgical care in the Gambia?
Thank you, sir, for the question. We are in a very promising trajectory. You realize before we had the pediatric surgeon, that was Dr. Jallo, a lot of the cases had to go back to abroad for treatment. Those who cannot, or the emergency, because there are some cases you must deal with them or do something before you refer. They were being handled by the general surgeons, and we thank them for handling the fort at that time. But you realize now with pediatric surgery, having a consultant, now we are 2, and the numbers growing, you realize that we are able not to be boasting, but we're able to do almost everything home, unless you want to go out. Something that is related to our specialty, we can proudly say that we can deal with it here on our own soil at the teaching hospital. So the trajectory is promising. There is a great promise. A lot of colleagues are also interested. We have 2, one who will be finishing by the end of the year. Another one is in training. So it is promising. And I can say parents and children are happier. You realize the smiles that we put into them, they come with hopelessness, despair, and being in pain. And you realize that your problem is being solved at home with very little expenditure on your side, because for under 5s it's free. Unless there are some 1 or 2 things that is not available in the hospital that you have to go and buy. But if you compare that with having to be referred, let's say, just to Senegal, which is the closest facility that you can go to, is expensive and out of reach for many average Gambians.
Absolutely.
So it's promising.
Oh, absolutely.
Yeah.
You're a specialist for children. Yes. What are the most common surgical conditions you treat among Gambian children?
Thank you, sir, for that question. The commonest conditions we treat includes groin swellings. We call it hernias. There is a misconception around that, children don't have hernias.
Exactly.
It's only adults.
That's what we thought.
And it's the commonest thing we do, yes. Because if you look at the way we are built through the Almighty, you realize that there is a high risk, especially for babies who are born premature, of developing groin swellings, and which would include the hernias, which would include hydrocele, where they have the swelling on the scrotum.
Yeah, why is that? Because you can't say it's the weight, on your waist area. Is it?
All right, interesting. So how it happens is it's commoner in boys. Why is sorry to use the testicles, the balls.
No, it's a big part of the body.
Yes. So
every healthy man wants to have
testicles. So during the formation of the baby, those testicles are developing very close to the kidneys, and they are located in the abdomen. Meaning,
is that
what
why
we call
they say they go up and down?
Yes.
People say they go up and down.
So
when they go up, they are going towards the kidneys.
Yes. So, but during formation, they are just beneath the kidneys, so they have to descend and go down. So before the baby comes out, around 7 months, it is just sitting at the groin, the entrance to the groin. So the groin is a passageway between the abdomen and the scrotal area. Okay. So by the time the baby comes out, meaning at 9 months, because that's when we say someone is term, around 37 weeks, the testicle would have passed the groin, which is the passageway from the abdomen to the scrotum, and drops to the scrotum. So when that happens, that's normal. But you realize if someone is born premature, you realize that time to transit hasn't happened. Okay, so the testis stays there, and that's why the groin swelling, the hydrocele, and the undescended testis have a similar cause. So when the testis drops, that passage is expected to close for one reason or the other. When maybe increased repeated crying, some babies who are not well formed, the musculoskeletal system is not fully formed, or for one reason it hasn't closed, because at the moment it drops, it should close.
Okay.
Then it has a passage where the intestine can go in and out. And then depending on the size, if it is big to allow the intestine, it becomes a hernia. Oh, wow. If it is very tiny and allows only water, because in the abdomen there is also water, which we call peritoneal fluid. That water trickles to the base of the scrotum, it becomes hydrocele, whereby it's a fluid collection. And if the testis hasn't had the time to drop, then it becomes an undescended testis. So it's as a result of the way we are formed as males, and then having that passageway closing and not closing because of different reasons.
Oh, wow.
Yes.
We're learning a lot. 8:34 is the time in the Gambia. So now we have you, and before you we had Dr. Cherno Jallow.
Yes.
Right? How has, your qualification, having the two of you, changed outcomes for families who previously had to travel abroad for care?
All right. Thank you, sir, for for that question. Having the two of us means we're able to do more cases.
Okay.
We're able to treat more patients, and we're able to allow more patients to be successfully treated and then go back home. Since he came, the referral rate drastically dropped. People were only going out based on choice. Now imagine you have two people, looking at statistics even. When he was alone, you realize that we were doing about 150, 120 cases in every 6 months. Now looking at last year, whereby the number has increased, by then I was a resident, I have two other residents, we had the opportunity to do more cases. So like this past 6 months, we're doing between 200 going to 250, up to 300 cases, because it varies based on the load of patients. So we're able to do more cases. We're able to also have a stronger team. You realize we are all there operating, we are sharing ideas, the outcomes becomes better. Rather than one is operating, you realize you have two specialists or two consultants operating, the outcomes is way better. You realize that you have better outcomes, and then your results are better. I'm not saying before the results are not better, but you realize that two heads sharing, you become more meticulous in whatever you are doing. So our outcomes continue to increase, continue to be better. And you realize that you've asked the question, what is the commonest thing to do? But I would just want to, with your permission, mention what we also do.
Absolutely.
You realize that we are able to deal with any surgical condition of the child, excluding the brain, the spine, and the bones. But we are trained to deal with the brain emergencies. For the brain, we leave it with the pediatric neurosurgeon. We have one neurosurgeon as well as a pediatric neurosurgeon, the same person, Dr. John Jabang. And the spine also we leave for him. The orthopedic side, the bones, we can deal with it, but most of the time we leave it for the orthopedics, because part of the training we are exposed to it especially. So, but you realize that, and then excluding the heart. But anything ranging from the chest, we've had surgeries that we've done in EFS, Edward Francis Small Teaching Hospital, where we had babies who were born, they could not swallow, because the esophagus, meaning the food pipe, is interrupted. And those people, if you have to operate them, imagine operating a 2-kilo baby. The biggest you would have maybe a 2.5-kilo baby, and you have to go through the chest, because that's where the interruption is. We've done those things a couple of times, and they've been successful.
Wow.
We've had opportunities.
We don't get to hear about the positive cases.
Yes.
It's only when, God forbid, the child dies on the operating theater that it hits social media.
Yes. And I would mention here, I will not say it has never happened, but our intraoperative mortality is nearly zero. Wow. You realize neonatal care is challenging, and hopefully when we go to our challenges and our way forward, we'll bring it. But they are very sophisticated human beings, the neonates. They are not only small adults. They need a lot of care.
Sure.
So in our little challenges that we are having, is something that we are anticipating to have, is more support on the post-operative care for those special babies after they've gone through a 4 or 5 hour operation. But we've also had experiences whereby babies are born and they couldn't go to toilet. We all know going to toilet is a normal physiology, it's a normal response for every human being. But those babies are there, they couldn't. And we've done complex surgeries whereby we have to, the first stage, divert, help them go to toilet, then they are able to eat and grow. Then we are able to come and recreate that passage so that they are able to go to toilet. It's also one of the commonest things we do back in the hospital. We have some patients who come and then the food pipe, meaning from the stomach to the small intestines, they are interrupted. We've had to go in and deal with those cases. So in summary, because of time, I would just want to say we are able to deal with a lot of conditions for the child and the baby that will need operations in the teaching hospital.
What facilities, equipment, or support systems are most urgently needed to strengthen pediatric surgery in our country?
All right. Thank you, sir, for the question. I understand you have a great audience and a very wide audience, so it will be a very important platform to mention this. As I started, neonatal care is very important, and we are doing fantastic surgeries, but we are trying to see how to resuscitate and support those babies after they are out. So that is one of the places whereby support can come in. Our colleague neonatologists, because we work hand in glove together, they are very fantastic, but it's one of the areas whereby more support can come in and then helping to improve our outcomes. Because you can do a fantastic surgery, a few days they are fine, but you want them to go home and be coming for follow-up. So that's one. The other thing is also having our own dedicated theater. At the moment, we are sharing theater suites with the different specialties. So we have 6 days that we are able to operate in a month as elective, and it's not enough. Every week we are able to operate 1 day, then every other week we operate twice. So that makes it 6 times a week. So because of space in that facility whereby we are sharing with other specialties. So having our own dedicated theater means that we can structure ourselves. The numbers are there. We're able to do more surgeries because the waiting list is there. We are clearing as much as we can. When we enter, our colleagues jokingly say Thursdays are day for your salary, work for your salary. Meaning when we enter pediatric surgery, we are there up to late in the afternoon. If it's up to us, we'll operate late night. Oh, wow. But because of logistics, you have to stop. But if you have your own dedicated theater, you realize that you structure yourself, you have your team, you can do as much as you can and then reduce the backload. Then the other support where support is needed would include, now the world is moving away from open surgery. And
what is also known as invasive surgery.
Invasive surgery. Okay. And we are all trained, my boss and I and my colleagues, to do minimally invasive surgery, whereby you do keyhole surgeries. You don't have to do a very big cut on the baby.
That's what you were mainly trained on.
So as part of the training, you are expected to be trained on it.
Okay.
So we did a lot of open surgery because you realize that pediatric surgery and minimal invasive is not the reverse, even in our part of the world. But in the West, it's the other way around, whereby. But we are trained to do that.
Okay.
So you realize that equipment-wise, we are challenged with having the mini instruments for those children. Because imagine operating a 2-year-old. We're using laparoscopy. So they need very small instruments like 3 millimeters, 5 millimeters based on the age.
And those are not available?
We have the 5 millimeters, but you realize that you can do bigger children. You cannot do smaller children.
Okay.
And
so
then
the equipment for smaller children isn't available?
Is not adequate. You understand? So there is support that is needed, but the smaller ones, the 3 millimeters, we don't have those ones. So we have for bigger children. So it's very important for collaborators and partners because government cannot do it alone. They are doing they're doing what they can, but I understand partners when they come in these things makes it better. Support on that side would be very helpful. And then the other part that I would say, our training also goes with our support staff, which would include the pediatric anesthetists. We have one interested in pediatric anesthesia, but having an area whereby you have also more pediatric anesthetists, because their physiology is completely different from the adult. So the more we specialize, we have nurses also specializing. I hope that would increase or help a better outcome, so that we have a global or a holistic package for children rather than just the pediatric surgeon.
Hearing that, you share the same theaters, with other specialists, leads me to want to know how important collaboration is, between, the different specialists. In the past 3 weeks, I've spoken to a urologist, an obstetrician, gynecologist. Now I'm talking to a pediatric surgeon. So how, important is collaboration between the different specialists?
Thank you, sir, for that question. It's very important. And you realize all the specialists you've mentioned now, there is a collaboration, or we work together. For example, the obstetrician...
Is that why you trained together? More or less?
More or less. Yes. I can say that.
Okay.
So if you look at the obstetric and gynecologist consultant, they are the ones who will be the first in contact with the baby, even if they are unborn. So sometimes we start our discussion and in trying to care for that baby before baby is born with the obstetricians.
Okay.
And in that discussion, we also have the neonatologists. So there's a lot of collaborations and multidisciplinary team approach. Because most of these conditions, you need all of these facilities or all of these specialists to be involved. For using the urologists, you realize that in pediatric surgery, there is a branch of pediatric urology. As pediatric surgeons, we are trained. We take over now most of the pediatric urology cases. But in our absence, they are able to do some of those pediatric urology cases, which I haven't mentioned, because some babies will be born whereby the urinary system where they are able to pee from doesn't come from the tip, the male child. So they'll be peeing from the undersurface of the penis, which we call hypospadia. So we have a good number of them. So we deal with them.
Wow.
But you realize that because of the collaboration, the urologist too is trained to know how to deal with that in the absence of the pediatric surgeon. So now with the advent of the college and all that, so we work together. So you realized all those specialists work. With the general surgeons, before the pediatric surgeons came, they were dealing with these kids. So I can say it's a healthy collaboration among all of these specialists in the hospital, because each one of us have a role to play in improving the life and livelihoods of these children.
What steps are being taken to train more pediatric surgeons locally? And what advice would you give to young doctors considering this path? I'm sure you would like to have more people follow in your footsteps.
Yes. Looking at it now, we need more pediatric surgeons. And the best way to do that is to train locally. It's easier, it's cheaper, it's less stressful. And you are training and you are serving your own people. So it's a very important step. So discussions are ongoing with the unit, the hospital management and ministry, as well as postgraduate office, in having accreditation for pediatric surgery. We are hoping to have our first visit in July for the college to come and see whether we are ready to train a pediatric surgeon. And we already have one who is finishing, one who has started, and we are trying to do an ad hoc, maybe until we get the accreditation, maybe whether it's possible to go to Senegal and come, like what was done for the urology resident who's now the consultant. So plans are ongoing. I can also say we have a WhatsApp group, a link whereby we share on all the doctors' platform for those who are interested in pediatric surgery. And I can say it's promising. At the moment, it's not like boasting about it, but we have become the hottest seat that people want, or place that people want to go to. Now, if you interact with colleagues, I'm coming. And that's the essence of doing these things. You realize that you go as the first batch or the second person, you do well, you motivate the younger people, and they will know that it's possible. And you realize that since I came back, the interactions I have with junior colleagues is like, yeah, it's possible. So when I'm done, I'm coming. Yeah. So I think the future is bright for pediatric surgery.
And possibly the stories of success, because you seem to have a very high success rate.
Yes, yes. So far we say, Alhamdulillah, success rate is there, but we can do better, and that's our aim, to have zero morbidity and mortality at the end of the day.
Earlier on, when we spoke about tools and equipment, there were certain tools that you were lacking. So this team that is coming now to evaluate, the readiness of the EFSTH to, deliver training locally. What if they came and didn't find those, tools available? Yeah. Also, the fact that you have to share theaters. I mean, you don't have a dedicated, theater and all of that.
Yes. So that's why we're doing a lot of groundwork to make sure at least we have a dedicated space for theater, and then making sure that we are able to do more. It's very important. But the college also understands the situation of the sub-region, because we are not alone in this problem. Okay. My training institution, when it was accredited in Ghana, they were sharing with the adults. Until now, we have our dedicated theater. So there is an understanding. With regards to the equipment for minimally invasive, especially for laparoscopy, you realize that we're able to do for bigger children. And then the challenges for the smaller children is an ambition that we want to do. But even in my training institution in Kolebo, you realize that for the smaller children, it's still a challenge. So it's not an isolated problem, and I don't think it's going to be a major issue in trying to deny us accreditation. So a lot of works are going, our data are intact, and works are going to make sure some of them are actually spoiled, and those things can be fixed and get a replacement before that time is due. Yeah.
What's been the most rewarding moment in your career, and what keeps you motivated?
The most rewarding, I can say there are many, but if I am to choose one, was having to do the thoracotomy, whereby this baby came in, could not swallow. Oh. Because there is an interruption in the food pipe. We had to go in, open the chest, deal with it, connect it, which is a very delicate surgery. Imagine you are walking, and then the child has to continue breathing under the machine, and then the lungs is coming to your way. So it was really fascinating. And then at the end of the day, it was successful. Child discharged, mom was smiling, and then the feeling is difficult to express, but I think it's a very, very great feeling, whereby you're able to see a parent looking at the face, the desperation, the despair, the hopelessness you see on their faces. And then at the end of the day, you come out and say, it was a success. Now we're going to the ICU to monitor your baby. Then at the end of the day, they are going and they come for follow-up. And, it's just a very great feeling. So, and that's why I say, I don't know whether I'm biased because I'm dealing with kids, but you realize that it's a very great feeling, because you realize the kids are the future for the future.
Of course.
And they need to be healthy.
Of course, yes.
And so we really need to make sure they are healthy. I know the kids may not remember some of them, the babies, but the parents are always, whenever we meet, you can't remember all of them, but they'll say, do you remember me? You did this for my child. I have a neighbor, and he said, do you remember? I said, no. He said, you operated my child so many years ago with a groin swelling. I said, how is he? He said, he's fine. He's going about his business. So only that puts a great joy and feeling that is beyond measure.
And it's also your motivation to keep going.
To continue going, because you realize the problems are out there. Yesterday we had a clinic, you realize that when you see these mothers with their children, you realize that we need to do more. We need to continue solving these problems to make sure that at least everyone becomes healthy at the end of the day.
What's the biggest misconception about EFSTH? I mean, the last 3 weeks I've spoken to, 3 of you. I mean, you people are inside. I'm sure you hear things.
Yes.
Said on radio, on television, on social media, definitely.
Yes.
And maybe walking around town.
Yes.
What's the biggest, which one would you hold up? There are many.
Yes. Thank you, sir, for that question. The whatever you are doing, no matter how much you do good, it's difficult to satisfy everyone. But the biggest misconception, the first thing I would start, healthcare is expensive. And government is doing everything it can to make sure that it's affordable and accessible to the population. So you realize that you come to the facility, you're giving the kids, they don't pay, but I will extrapolate it to the adults, whereby you pay like say $100 for ticket.
Yes.
Because according to plans, it's called consultation fee. Then you're able to get medications, you're able to see the doctor, and then you're asked to pay some few services. But if you're asked to remove money, or they tell you, okay, this thing has gone down, go out and do this, or this medication. Because when government is buying medication, there is essential medications, what we call essential list, meaning those basic minimum should be available. But sometimes we write for you some specialized medications you have to buy, and it becomes an outburst. You are not happy. And you realize that the population is growing.
It is, yes.
There is high demand for expansion. Expansion is going on, but you realize that it's not matching with the population growth. Yes. Hopefully when the Farato facility is opened, it will try to decongest. But people have to understand that, and I'm happy that government is trying to do things to make sure that the congestion happens. But those are the things that people have to understand, that you come sometimes, the A&E is choked, because emergencies are not waiting for people. It's happening anytime. So you realize that time of transfer or the commotion and all that, some people become impatient. You start seeing pictures all over. But a great number is just not understanding how the system works. And I can say this, I'm not bothered or like feeling bad about those things. It becomes a motivation to see, okay, some of these criticisms are positive. You realize that it helps you to look at, okay, there is this gap, we can do better. Okay. And then I personally would see that, okay, how do we make sure that these things is improved, and then the next client will not complain. Okay. So it's a win-win situation, but some of them can be too much, but you cannot stop people.
Absolutely.
And so we just have to continue and doing the best within our limits.
So just finally, where do you see pediatric surgery in the Gambia in the next 5 to 10 years?
Yeah. Our dream is to have a pediatric surgeon in every major facility in the country, because we will not want someone all the way from Basse traveling 4 or 5 hours if it is an ambulance, and if you have to come for yourself longer to Banjul to access care. But if you're able to have it in every major facility, that's our dream, and we are hopeful, because with the numbers that are already there, the numbers that are coming, the interest we are seeing, if we continue, and we are willing to continue with the support, you realize that that can be achieved. And it goes along with the other allied facility, like having the pediatric anesthetists with us, having the dedicated OR pediatric nurses with us. So that's our dream, and to make sure that no child will be referred out of this country to access pediatric surgery care unless it's your will. So that's our dream, and I can say it's very promising and hopeful.
That's great to hear. Just finally, if you have any one message for the viewers, the listeners, what might that be?
All right. Yes, just to tell our viewers and our listeners is pediatric surgery was not heard of in the country. Most of these things were done by the adult surgeons. Since 2021, we have someone on the ground. We are available, and we are in Banjul to help with conditions of these beautiful kids, to take care of them. So if you have concerns, or you have a child with a problem that needs surgery, meet us in Banjul. You don't have to worry, how am I going to make sure this is done and how it's done. We are there, we are available, and I can say the team is a very receptive team, and we are available to help improve the livelihood of children. And we are very grateful to the support that we have received so far, starting from the government through the leadership of the country, His Excellency Mr. Adama Barrow, Ministry of Health, the Health Minister, who is my trainer when we just started, and the hospital administration, and to all partners, including Kids OR and Smile Train, for the support we continue to receive in trying to improve care generally, because it's not only pediatric surgery that is flourishing, but other specialists are flourishing. So, and then at the end of the day, we want to see a healthier Gambia, see a healthier population, starting from the children up to the elderly. So thank you so much.
Older persons like Uncle Peter and others. Dr. Abdoulie, thank you very much for your time.
Thank you so much, sir, for having me.
Sant Yàlla.
looy xaar utal wéef nga scan nga fay te nag doo ci yokku dara.
Jar Oil Company stands tall as a trusted name in energy, keeping the Gambia moving with service stations across the country and a commitment to innovation and reliability. In Farafenni, Jar Group is reshaping our industrial landscape. The Jar Oil Cement Factory can produce up to 100,000 bags a day, reducing imports, creating jobs, and building a stronger Gambia brick by brick. And in the heart of the Central River region, Jar Farming Initiative is cultivating food security. With thousands of hectares under development and modern irrigation, Jar Farming is turning the Gambia's soil into abundance. Jar Group is more than a company. It is a vision of self-sufficiency, resilience, and progress. The Jar Group of companies, investing in industry, agriculture, and energy, building the Gambia's future today.
A better way to pay your UTG fees with instant proof of payment and real-time student portal update. Paying your University of the Gambia fees has never been easier or more convenient. With EcoBank, students, parents and guardians can pay UTG tuition and related fees through our secure digital banking channels such as EcoBank mobile app, EcoBank Online, and EcoBank Omni Lite. Once payment is completed, instant proof of payment is generated and the UTG student portal is updated in real time, allowing students to proceed immediately with registration, course selection, and clearance without unnecessary delays, while giving parents and guardians peace of mind that payments have been successfully processed. How to pay via the EcoBank mobile app. Open the EcoBank mobile app and navigate to the home screen. Select Pay Bill. Choose Pay a New Bill and select Schools from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. How to pay via EcoBank Online or Omni Lite. Log in to EcoBank Online and Omni Lite using your credentials. Select the menu and choose Bill Payments. Choose Quick Bill Pay and select School from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. Walk into any EcoBank branch or pay through our digital channels and enjoy instant proof of payment with real-time updates on the student portal. EcoBank, the Pan-African Bank.